Every health system leader has executive management challenges facing their organization. This show supports leaders in addressing those challenges with cutting-edge information, leading strategies, and sharing best practices. Listen in and gain keen insight as industry leaders share their stories. The Baldrige Foundation welcomes you to Leader Dialogue Radio.
Hello and welcome to Leader Dialogue. I'm Dr. Roger Spoelman. I'm your host for today's discussion, and I'm so glad you've tuned in today to listen to another conversation with some of the most fascinating leaders in healthcare and in other fields. Before we get started, though, I want to thank the Baldrige Foundation for making Leader Dialogue possible, and also to give a shout out to our sponsor, About Healthcare. And speaking of about healthcare, I'm joined today by my good friends and colleagues, Ben Sawyer and Dr. Darren Versillo. These guys are both executives at About, and you've grown to appreciate, as I have, their real insight, their keen ideas and thoughts about healthcare and about some of the challenges that we're facing today. Well, this conversation is going to be both interesting and really helpful. Our guests today are two of my very favorite nurses, and I've had the privilege of working with both of them in my career. We're going to talk today about systemness and operating as one system, employee empowerment, and some seamless handoffs and things like that. And as I said, these two guests, these two favorite nurses of mine are Kim McGuire. Kim is the Executive Vice President and CNO at Northwest Community Healthcare in Arlington Heights, Illinois. It's a magnet recognized designated system, and Kim is fairly new in her position there, but we've had the opportunity to work together at Mercy Health and Trinity for many, many years. And she's just as I said, one of my favorite, not just nurses, but favorite people. We've had a great time working together. Well, Kim was actually the successor. Her predecessor in her job a number of years ago was Dr. Gay Landstrom. And, Gay didn't have enough initials after her name, like a lot of nurse executives. So she needed PhD. So she left us and went to University of Michigan to get her doctorate. And she has since done some amazing things. She's worked with Dartmouth-Hitchcock Health System. She's worked with Ascension, St. John's, and she was at Trinity before, and now she's back at Trinity Healthcare. Trinity, as you know, is one of the largest health systems in the country. And she is the Senior Vice President and Chief Nursing Officer for Trinity Health. Some just interesting fun facts: 34,000 RNs at Trinity and 13,000 staffed beds, 100 hospitals, about 100 hospitals, and 100 continuing care sites. So, Gay, you must be exhausted with all of that. But Kim and Gay, it is so much fun to have you on the program today with us. Thank you so much.
Thank you for the Great to be with you, Roger.
Yeah. Well, and I'm really glad to introduce you to my friends Darren and Ben, and we're going to have a great conversation about these very important topics: systemness and seamless care and handoffs. And we were just talking before we hit record about some of the challenges that you as healthcare leaders are facing today. And we don't want to slide into that thing where everybody's talking about the pandemic and they kind of get stuck. And I know that for a fact that the two of you are fully aware of the challenges, but you're not satisfied to just sit and admire the problem, but you will get to work and try and make solutions for this problem. And I know you've both been doing that prior to the pandemic, and some things were put on hold, and some things now you're saying, listen, this isn't going to last forever. We got to get busy. So could you just talk, first of all, let me go to Kim first. You're on the front lines. You're doing this every day. You've got to keep your staff engaged, and you can tell us if you want how many openings you have. I know Gay and I talked about how many he has system-wide. It's quite a staggering number. But, what is your greatest challenge, Kim, in a community health system right now as a chief nurse exec?
Yeah, thanks, Roger. First of all, I just want to thank all the healthcare workers out there that are listening. Thank them for the last couple of years, especially. I know we don't want to dwell on it, but it's been a rough couple of years in healthcare, as everybody knows. And so I just want to acknowledge everybody in healthcare and thank them for the hard work that they've put in over the last couple of years.
As do we.
I'd say our biggest challenge at NCH where I am right now, and probably not unlike any other healthcare system in the country, is staffing. We're still struggling with our staffing. We have a fairly substantial vacancy rate here, both for our RNs as well as for our nursing assistants. And that stretches into other disciplines as well, such as respiratory therapy and surgical technologists and so on and so forth. You know, our nurses are tired, they're weary. That's the word I use a lot. Weary is the word. They're still engaged, they're still committed, but they are tired and they've been really tempted by some of the agency dollars that are out there. And so I think that's why we've seen a little bit of a turnover here at NCH. And so we've been really working on different things that we can do here in Chicago to help them stay in their organization in place and stay engaged. And we've had some success with a couple of tactics we've put in place, but that's our biggest issue right now. That and the acuity of our patients. Our patients are really sick. These are the sickest patients I've seen in my entire career as a CNO and as a nurse. And, you know, patients that we used to see in the ICU, we're seeing on med surg now, which is, you know, very normal. And so we're dealing with high acuity and very tired staff right now.
Yeah. Well, thank you for what you're doing, Kim, and we do have an appreciation, but I want everyone to have an appreciation for what your challenges are and what you're doing. Gay, you through your system, through Trinity, have been working on some ways, because this is, you know, it takes what Kim's situation is and multiplies it across about 100 other facilities. So, you know, what's your RN vacancy rate, Gay?
Well, I share, you know, everything that Kim said is absolutely true in the 25 states where I have facilities. Our vacancy rate is really approaching in many of our ministries 20%. And that really matches the numbers that we've been seeing across the country. 1 in 5, you know, healthcare workers have left the bedside and they're doing something different. And we had some vacancy before this pandemic hit, but it's clear that the pandemic really shifted things for a lot of clinical staff. And it's not that we're just seeing that what we were becoming aware of prior to the pandemic just accelerated. So prior to the pandemic, a good year before the pandemic, we had been doing quite a bit of work, really trying to listen to staff, nurses, respiratory therapists, a lot of those caregivers that are part of the interprofessional team at the bedside in an inpatient area. And what we were seeing was that what they needed and wanted in life was changing. And what they needed and wanted, that all accelerated during the pandemic. But my point is, it started before that. And I think it might have been more subtle. And I know some of my colleagues that I talked to across the country somewhat, I think, resisted the thought that it was shifting. And I described the shift as our nurses and respiratory therapists and others were wanting to have more control over their schedules and their lives. And they were becoming, and it wasn't just the young, you know, newer generations. It was a bit more mixed than you might assume. And they didn't want to beg for vacation or have to wait till they'd been there 20 years and have enough seniority to get what they, you know, really desired, and taking that family vacation, or always having to work half of the holidays, working every 2 or 3 weekends. They were willing to work very hard and bring their expertise to patient care, but they needed more control. And I think in our historic roles, those full-time or part-time FTE roles, we weren't giving them a lot of flexibility, and they needed more and more and more flexibility. And we needed to be responding to that. And then pandemic hits, and that's all anyone is talking about is is the value proposition? What kind of money can they make for this really dangerous hard work they're doing? And what kind of flexibility could they enjoy? It suddenly is, right at the forefront. So just in short, I'll share, we began developing a national, for lack of a better term, sort of an internal agency to give a place for clinical staff to be able to bring their skills and their experience to patient care, but they could control their schedule, and they were compensated well for it. And sort of that you don't get many benefits, but you're making a good salary, more similar to travel agencies. And when the pandemic hit, we also launched a national traveler program. So we had both regional and national ways for staff to work for our company and care for our patients and align with our mission and vision. They didn't have to always go to an outside firm to get what they needed.
Yeah, Darren, I'm sure that you've got a lot of thoughts and comments about this as a practicing hospitalist. You've seen some of the impacts of this, I'm sure. So share with us what your thoughts are.
Thanks, Roger. First of all, on an audio only podcast to see all the nodding heads here in the background as Kim and Gay have been talking about the things that they've been sharing. I think we're just all in violent agreement of everything that they've been talking about here. So thank you for sharing and all you're doing. In my experience, we've been seeing the same thing in the Salt Lake area where I practice, and seeing some of the statistics. The 20%. Great resignation rate or the move on rate, and the 10-year process it's going to take to replace all of these, and the increase in ER boarding and transferring patients because we don't have staff, and I think it was Kim that was mentioning making these decisions to put ICU patients on a tele ward and tele patients on a medical ward that is just reaching the radio limits of your wireless telemetry so you can take care of these patients. I mean, it's all these things that we're dealing with. You have to adapt, right? It's adapt or fail, and some of the things you've talked about implementing, I think, are probably of great interest to many organizations around the country. I wanted to pose a question to you. One thing as a hospitalist, it's always been extremely gratifying and reassuring to me in working with the nurses that are either in the ICU or in step down tele, med surg, what have you, is their ability to be critical thinkers and to really analyze situations, to think outside the box, and not just do, but to think and to go one step beyond. And so, how do you take your nursing staff? And you're right, they're weary and it's tough. How do you keep them critically thinking about what's going on and reward them for that, so they continue to do that, and we just raise the bar of how they're in their practice?
I can start with that. One of the things that I did in a previous role or in a previous organization is, especially early in the pandemic, we took nurses in our med surg areas that showed some interest in critical care, but could never crack into critical care because there were never any openings. We created a tiered system. And so we had, I think it was tier 1 through 4. And if you were considered a tier 4 nurse, we could put you in the ICU on a team with an ICU RN. But with that came additional educational opportunities. And so we would tier them up, if you will, and that's how we kind of stretch our RN resources that we had during the early part of the pandemic. And what we ended up with, pleasantly, is that when we did have openings, we had a slew of med surg nurses that were ready to go into the critical care area because they had been working alongside very experienced critical care nurses and critical care physicians. And so they had a safety net of learning, if you will. And so that kind of honed in their critical care or the critical thinking. And so we maintain that going forward to help with that. And that's something we're looking at doing here at NCH as well, is having these additional educational opportunities to help our nurses grow in their their ability to take care of a sicker population. So,
Well, and I'm glad you shared that, and that idea of nurses being able to graduate up through that, those higher acuity patients, and that idea of critical thinking, not obviously to be equated solely with critical care, but that critical thinking capability on any level of care is just raises the quality of care as well. So no, thanks, Kim. I appreciate that.
I know one of our themes in this conversation is systemness. And one of the things that we did within Trinity Health, again, starting it before the pandemic, but I was grateful that we had started this before the pandemic. We knew that we really needed to increase the development of our nurses and create some opportunities for them, even before they might move into a specialty area, to be able to gain some greater knowledge, to be able to really think through complex care, because frankly, I know Kim would agree with this. There are no simple patients that have a single condition. They're just not,
Right.
they're not going to spend a single night in the hospital. These patients, if you look at some of the Medicare data, they've got 4, 5, 6, 7, 8 comorbidities, and that takes some really serious planning. And nurses need to be able to think critically and creatively in putting together plans of care in that kind of context.
Absolutely.
So we began developing what we called an academy program. And if a nurse was thinking about career-wise wanting to become a critical care nurse or a care manager, or move into surgery or the emergency department or any other specialty area, that they could be a part of a 6 to 9 month academy program where they could we did set it up virtually, but they could learn from experienced nurses. They could gain some of that knowledge and bring that to their patient care, the unit that they're on, even if it's a med surge unit. But we could really increase the ability of nurses to think about complex care. And so we had started that, and we're continuing to expand it, and we offer it to our nurses across all of Trinity. It'd be more challenging for an individual hospital to develop it alone. So we really leveraged it across our system. I will make one other note that is an emerging challenge for us. Is that, and I know this because we've been doing a piece of research, really interviewing brand new nurses and nurses or students ready to graduate from nursing school. Their education has really been very disrupted over the last couple of years. And for many of them, they were really missing a lot of their clinical experience in learning from experienced nurses. Some weren't even able to get into simulation labs for many, many months. And so we have nurses, and I know this impacted other clinician education programs as well. We have some young clinical people coming out of their programs with very different experience and development. And that is causing health systems to really need to augment that, recognize where they are and help to develop them into the clinicians that we need. But it's not the same product coming out of programs, at least over the last couple of years. So it's another challenge, and one that, we're all embracing and figuring out.
I think Gay makes a really good point, and I want to expand on that a little bit, because we've been seeing the same thing here at NCH. And so the expansion of residency programs for nursing, I think, is very, very important. When you talk about what do you want your CEO to know about, we need to expand our residency programs, incorporating simulation into those programs, because we're experiencing that as well. Nurses just did not get the same training during the pandemic.
I was just going to jump in there and ask, maybe this is a simplistic question or doesn't have a simple answer, but are you both seeing more of what about the age cohorts? Are you seeing more of your resignations or people leaving the field? Is it the seasoned, the nurses that have the most experience, or is it across the board? And the other thing is, are you seeing younger nurses choosing this as a profession, or have the numbers dropped because of how crazy things are?
I don't know about you, Gay. We're seeing a mix.
Yeah.
We're seeing a mix.
Yeah. Well, the other part of this, and Darren, you know this to be very true, that newly trained physicians, and Gay, when you talk about newly trained, the disruption that occurs in nurses training, I know some young people who are in medical school or have been in medical school,
Right.
and they've been horribly disrupted. And I
Yeah.
think, oh my goodness, they're nice people, but I hope I never have to rely on them as a physician, because I don't know what their training's like. And you compound it because you've got, Darren, you know this, that who's your best friend as a brand new doctor or as a resident? It's the experienced nurse.
Exactly.
So if they're not there, my goodness, we have lots of challenges.
I have a daughter and a son-in-law, both in medical school, and they're experiencing that exact thing. The lack of being able to get the clinical experience, and are having to travel all over the country to find those experiences. And Gay and Kim, one thing that apart from my clinical work with About Healthcare, something that we work extensively with is transfer centers and access centers. The best model there is to staff them with experienced nurses so they can interact with those providers as they're calling in. And one of the things that just came to mind was as you see people shifting around to different areas, whether they're on the wards or have other opportunities to go into something that maybe isn't so bedside intensive, like being in an access center and then working with kind of care traffic control in that environment. I see such great experienced nurses getting into those environments and providing services within organizations where they just keep getting more and more added on to the work that they're doing in these access and transfer centers, because they are so capable. They have so much experience, and they can help create, as you mentioned, Gay, systemness. So they can help load balance across the organization. Have you been leveraging that within your organizations to do those alternative sort of services as well?
So I'll jump in and answer that. We have been doing a lot of work with looking at what our care model needs to be in the future, recognizing that the country is short of registered nurses, short of even LPNs and nursing assistants. Everyone's vying for nursing assistants. Even McDonald's is competition now. It's crazy.
Yeah.
The competition for that entry level worker is just compounding. So we really have to pay attention to not only attraction, but reasons for people to stay in those professions. But to your point, we've really been looking at how do we create roles that those nurses who are retiring early, and we saw that during the last 2 years. That's one of the groups that we were losing. Not only all that experience, all that knowledge, those are the ones who also mentor our newer minted nurses. So losing that component is really, it causes a lot of issues. So one of the things that we've focused on is how can we create roles where we can really encourage those nurses to stretch out their career a few more years. We need them to stay in nursing longer. And if that's not at the bedside, hiking up and down hallways, how can we bring them into patient care so they can help with complex care, so they can mentor those young nurses, and they can be a really vital part of the team? And how do you make a role and a value proposition that will entice them? And I've been talking to nurses that retired in the last couple of years, and I've talked to them about if you could be a virtual nurse, part of a care team, but you're not actually in on that floor, that inpatient unit, but you can be a part of working with the patient, helping with assessments and complex care planning and mentoring a young nurse. Would you do it? And I have yet to have one of those nurses tell me no. They're really interested. So
that's great.
We're doing a lot of work in that direction, and I am convinced that virtual roles for probably nurses, pharmacists, case managers, lots of different roles, there will be a role. And I think it's our future.
So you're talking about maybe creating programs, and Kim, I don't know if you're doing the same thing, but kind of an off ramp, sort of a gradual off ramp, rather than saying I've had it, getting to the frustration level, say I just can't take it anymore, which is horrible. We haven't touched on the behavioral health, mental health challenges and issues. We should do that for another podcast. But can you create an off ramp where, as you said, Gay, stretch it out just a little bit more? Don't send them into retirement completely used up and overusing alcohol and drugs and stuff because they had to cope with it, but actually a nice, easy off ramp where they're contributing to the day that they leave in a very positive way. Have you seen that? Have you been able to utilize that system?
I personally have not, but I'm calling Gay after this podcast. I have her cell number. Great. Well,
The
only other thing I wanted to mention was we're doing, I think the other thing we have to really hone in on, and I know Gay is doing this, is working with our academic partners with apprenticeship programs and releasing some of our senior nurses to teach, because we have a problem in nursing with having enough instructors. And so we're trying to do more and more of that here. Back home, I did that, and I'm trying to do more of that here as well in Arlington Heights. But that's another opportunity, I think, for us in healthcare, is to really have stronger partnerships with our academic partners.
That's great.
Kim, and some of those combined roles for a nurse who's an active clinician, but frankly, the patients are very, very acute, and it can be difficult for them to stay in that work. If they have a blended role where they might also be teaching in a program, that gives them respite and allows them to go back to the bedside with some renewal. And I think it contributes to resiliency. So those blended roles, I think, are kind of brilliant.
Boy, I remember some of the things that we worked on, were saving physicians and nurses from burnout. This was before the pandemic, and we had no idea what was coming. But some of those things kind of went by the wayside because it's just the tyranny of the urgent. You're just in the moment, just trying to survive. So hopefully we'll get back to some of those things in the near future, won't we? Some of those more proactive measures.
Absolutely. I do think we're the challenges of the workforce. We've got years of working on this, but we need to keep our eye on that long range plan, not just digging out of this challenging hole, but where we need to go beyond that.
Well, I knew this was going to happen. We're sort of at the end of our time, but I'm going to ask Ben to talk about something in a minute. We have been so fortunate to have the two of you on this podcast. Thank you so much. But we've just for our audience, we have a webinar coming up, and we've also twisted those arms to get you to be on our webinar, to have this roundtable discussion, to further this very important discussion. And Ben, could you just tell our audience a little bit about how they can get involved in that?
Yes, absolutely. So there is a webinar that's titled Systemness and Operating as One that Gay was just referring to. It is on February 22nd at noon Central, and people can sign up through the Baldrige Foundation Leader Dialogue program. The registration link is on there. It's at www.leaderdialogue with the GUE ending .com, and you can find that in the event page and sign up for that. And we'll continue this conversation, which, by the way, was really fantastic, Gay and Kim. We really appreciate it. The thing that stuck out to me in the conversation was a lot of these trends were happening before the pandemic hit, and it accelerated it. And the comment you just made, Gay, which is you have to respond in the moment, but really the goal is to be able to look at the horizon and say, how can we make changes? Because healthcare has changed, right? Probably permanently. How do we make changes that can get us in the right place going forward in the future for our patients?
Well, that's so true. Thank you, guys. Thanks so much. We've come to the end of our time. If you've been taking notes, I hope you have been. You can go back and listen. You've heard some really innovative solutions to some really difficult challenges. And we want to thank you both, Kim and Gay, for the leadership that you're showing in this really important time and in your work. And Darren, thanks for your questions and comments. Ben,
Thank you.
we are grateful. There are lots of podcasts. We're so grateful you decided to tune into this one. And we hope that you really got some creative solutions, but join us on our webinar in a couple of weeks. And we'd love to have you have an opportunity to submit some questions to our panelists in our roundtable. So thanks so much for listening. Thank you again to our guests. Keep leading in this very difficult time. We need you. Your patients need you. So thank you so much. We'll see you next time.